Hey guys. Yeah, I'm finally getting this out there for you. I apologize for all the confusion with me not being in class yesterday. But it was just not a great week. So anyways, I want to get this out and so you guys have it for next week, and for all those who did have class this past week, you can listen to me, I guess, if you really want to. So let's get started. So why do we give blood? We give blood for any cases where there's trauma or a hemorrhage. Anytime that the person has like a GI bleed, it might be anemic, car accidents, or maybe it's like, I don't know, things that come to mind are like logging accidents with chainsaws. But I think the most common one that I've seen is like the low hemoglobin, low hematocrit, in relation to like a GI bleed or a bleed that they can't find. Another reason we give um, blood is for the clotting factors. Some patients don't have the clotting factors that are needed and are at high risk for bleeding out. So what are the different types? And I want you guys to know these. I think it goes into, we'll go into deeper as we go along. But there's whole blood, there's packed red blood cells, there's platelets, there's fresh frozen plasma, and there's albumin. So what do all of these do? Um, Whole blood and albumin basically restore that intravascular volume. Packed red blood cells, they're going to restore the hemoglobin, the oxygen carrying capacity of RBCs, and then clotting factors and platelets help with clotting. Most common blood transfusions are allogenic or homologous, just basically meaning that that a person donated it to be transfused to another person. So that being said, every time blood is sent to the blood bank and ordered, there's so many steps that come into play to make sure that the donor's blood is compatible with the recipient's blood. Things like improper labeling, or maybe a poor handoff, or just a poor process of the blood requisition. If you guys have ever seen how blood's given, the nurse goes down to the lab and they are very almost, it's just a routine of what they go through and double check with one of the lab people, and then when they get back up to the floor, they'll do it again with another nurse at the bedside with the patient. Our notes say the disease transmission is also an issue. I do know that a lot of the blood is always screened for diseases. Like example, the HIV virus, when it was first coming out in 1981, it took until about 1985 until they could actually, or that they actually screened it for AIDS or the HIV virus. So now, since then, the disease transmission from a blood transfusion has really gone down. Back in the early 80s, though, that was a big, sorry, I say a lot when I'm recording with my computer. It drives me crazy. I can't imagine you guys. I forgot what I was saying. Keep going with my notes. An autologous transfusion, you guys will hear that, is a patient's own blood. We'll go into that further in the slides. Or I think it's towards the end. So, whole blood, packed red blood cells, fresh frozen plasma, platelets. Packed red blood cells generally, and I want you guys to know this, know what each type of blood component is given for. So packed red blood cells, there's the whole blood, is generally about 400 ml. When we give the PRBCs, it's generally, rule of thumb is that it's going to raise the hemoglobin 1 point. So if their hemoglobin is 7.0, we give the blood and then we recheck their hemoglobin, it's hopefully going to be up to 8. So it's just 1 point that it'll bring it up. Things that we use the PRBCs for is if a person is anemic, if they're having symptoms. If a person has a low iron count or low hemoglobin, but they're not symptomatic, they may kind of hold off with a transfusion. But if they are symptomatic, if they've got orthostatic hypertension, hypotension, they're flushed, they're dizzy, things like that, then yeah, they give them a unit or two. Or if there's acute blood loss, like the hemorrhaging and the GI bleed and the anytime that there's a major blood loss. Platelets are given for thrombocytopenia. Anytime that platelet level drops, a person may be given platelets. Generally, a unit of platelets will raise them up about 10,000. And remember, platelets are used for clotting. So the patient that is thrombocytopenic has a risk for bleeding, and that's why we're giving actual platelets. So fresh frozen plasma is another thing that we use for clotting. Generally, it's about 200 to 250 mLs, and it needs to be used within 2 hours of the time it thaws. It's usually it's stored frozen. Albumin is used for hypovolemic shock. When a person goes into hypovolemic shock, the albumin is administered. It's a hyperosmolar solution, so that just means it's moving the water from the extracellular compartments into the extravascular compartments into the intravascular compartments, therefore expanding the blood volume. So remember, PRBCs, anemia, acute blood loss, things like that. Platelets for helping with clotting. Fresh frozen plasma contains clotting components, and albumin is generally used in things like hypovolemic shock because it's an expander. Going back into a little bit more detail with platelets, like I said before, and some of these slides in here are repetitive, but platelets are given for thrombocytopenia, or if the platelets are dysfunctional. Platelets will be given when a person is having bleeding that's related to a low platelet count. It can also be given to somebody who is at a high risk for bleeding because of a low platelet count or dysfunctional platelets as a prophylaxis, just to be on the safe side so they're not bleeding and then trying to, catch it back up. Rather, we're doing it before they actually start bleeding. Things that people might be given platelets for: leukemia, aplastic anemias. Sometimes medicines can actually destroy the platelets. So those are just things that we would give the platelets for. Albumin, like I said, it is a plasma expander. And this is when the patient would have an excessive protein loss. Because remember, protein is good for healing, and it's a kind of a marker for malnutrition. So when would they have protein loss or need albumin? The burn patients are the ones that really need this. As well as the hypovolemic. But the burn patients are losing all the fluid from the wounds, are draining, and that's where the albumin comes in and bumps up that protein level and helps heal it. So remember, albumin is for things like burn victims, which could actually go into hypovolemic shock. All right, blood type and screen. Type and screen. Anytime a patient is admitted or for any disease or illness that would be. Let me restart. anytime a patient is admitted for things like surgery or diagnosed with any type of illness or disease that would cause bleeding, they're actually typed and screened right away. You've seen that it's the red bands they wear. It just says what type their blood is and screens for any other issue, for the ABO type, RH factor, and the HLA. Cross-matching is done once the patient is ordered to have a unit of blood. It takes the patient's blood and a little bit of the unit, and make sure that they're compatible. So that it's not, maybe they're going to have a hemolytic reaction, which we'll get into further in the slides, but a hemolytic reaction where the blood actually attacks itself, kind of. But they want to make sure that's not going to happen outside the body before we put in all that blood into the patient's body. ABO system. You guys have heard this, type A, type B, type AB, type O. The ABO system tells us about specific antigens that are present or not present on the surface of these red blood cells. So, if you look at it, type A blood has anti-B antibodies and the A antigen. Type B blood has the B antigen and type A antibodies. So if a person with type A blood is given type B blood, those antibodies are going to attack the blood cells. Type AB, they don't have either antibody. They have A antigens and the B antigens. So these guys are known as the universal recipient. They can get anything. Type O blood have both A and B antibodies. They don't have any antigens. So they can only receive type O. So hope that all makes sense. Type A has the A antigen, B antibodies. Type B has the B antigen, type A antibodies. Type AB has the AB antigens and no antibodies. Remember, they're the universal recipient. Type O has both A and B antibodies and no antigens. They can only receive type O. Alright, RH factor. You guys will have to go over this in promotions too if you haven't done that yet. So if the body contains the RH antigen, the blood is RH positive. If it does not contain the RH antigen, the blood is considered RH negative. So this doesn't really come into play until baby number 2, 3, 4, whatever. So if mom is RH negative and dad is RH positive, that baby has a very good chance and most likely will be RH positive. So in the first pregnancy, it's not an issue. Mom's blood is on her, it doesn't mix until delivery. So mom's got her RH negative, baby's got her RH positive, no mixing is going on until that delivery. Well, at delivery, the baby's RH positive blood mixes with mom's RH negative blood, and mom starts making antibodies to that RH antigen. So, a year down the road, mom gets pregnant with baby number 2, and now mom, since she's RH negative, has built up RH antibodies, and that baby has the antigens, that mom's blood is now going to attack that baby because they see it as a threat. So that's why they get the RhoGram, because that helps with that whole process. If the baby, there can be so many issues. It can actually cause the baby to pass away. It can cause jaundice. It can cause anemia. There's a whole lot of things. It can cause death. It's kind of a nasty deal. Alright, so when I first looked at this slide, I could not figure out why it said donor. So if you remember that the person who can donate blood to anyone is type O. So universal donor is type O. Universal recipient is an AB positive. They can receive anything. So that's, if you're type O, you are very, 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 very important to donate blood. All right. Getting ready to give a blood transfusion to our patients. It's our responsibility and the doctor's responsibility to educate the patient on the risk benefits, what it's going to do, how it's going to make them feel. Anytime that there is, or educate them on the signs and symptoms of reaction, all those things. It's our responsibility and the doctor's responsibility. The consent for blood needs to be signed in front of the doc. And then the doctor will sign it as well. And then before we give it, we need to make sure that that consent is signed. So if you think about when somebody comes in for a day surgery, that is one of the things that is just, it's on the checklist of things that have to be done. Even if they don't think that there's going to be a risk or a issue with it, it's not a planned transfusion. If they go into surgery and there might be acute blood loss, the patient will sign a consent form that says, while I'm back there, please give me blood if I'm out and there's an issue. So that's just one thing that we need to do, is we need to make sure that that consent is signed. If it's in a surgical situation, we need to make sure that before we take the patient back to surgery, that that consent has been signed. Alright, so assessment. Like I said, informed consent signed by the provider and the patient. That's our job, to make sure that it has two signatures on it. We need to make sure that there's a doctor order. We need to make sure that the lab results reflect. Generally, I think it kind of depends on providers, but it's generally 7 and below hemoglobin is when we transfuse. We need to look at allergies, and if there's been any issues with reactions or transfusions in the past. Also, double check any pre-transfusion medications. Those are things like Benadryl and Lasix, just to help with some of the sensitization and maybe keep them from going into fluid overload. I have seen the most common time Lasix given would be like when they order 2 units of packed red blood cells, give Lasix 20 milligrams in between. And then vital signs, but we'll get into more of the vital signs when we do it. Oh, what else is in the notes here? I'm not sure why this is on this slide, but when we have an elderly person, we need to make sure that we're transfusing it slower, just for the pure fact that they're more at risk for side effects from this. Like if they are have a poor heart function, they're at a higher risk for heart failure, pulmonary edema, fluid overload. They're at risk for all of those much easier than the normal person. Another thing that's on here, we need to be very, very, very cognizant of like kiddos and patients who are confused or even mentally challenged or the ones that are in a coma, just because they have trouble communicating any issues. Maybe they are experiencing low back pain and they can't tell us that, and that's a sign of hemolytic reaction. So then it's up to us to really watch and see if they're reacting in any sort of way. All right, assessment. First thing we need to do is check that IV site. IV should be an 18 gauge or bigger. 2022 might work, but we really want to keep it generally to a size 18. Just because the larger the bore in the IV, or the larger bore of the IV, it's going to prevent destruction of that red blood cell. So if it's a smaller bore IV, it's trying to squeeze and it's being pushed through there, and it might break it. Notes on here. We might need pressure bags or maybe warmers or leukocyte depleting filters, which I've never used those. I've used the pressure bags and the warmers. But pressure bags are just, instead of infusing the blood over 4 hours, you put the pressure bag in. It's kind of like the one that I used was kind of like a blood pressure cuff, and we put it around the bag of blood and then pumped it up, and it squeezed that blood in quickly. Warmers we're going to use like if maybe somebody's, oh gosh, my brain is fried. It's like 1 o'clock in the morning. Cold, hypothermic. We would be giving them warmed blood. Notes on here, and I think it's in here in another place too. When a person gets an order for blood, we want to make sure that that IV is patent. Because once we pick that blood up from the lab, we only have 30 minutes to get it started. And if you are coming back and you see that their IV is not working, it's going to take 10 minutes to get a new IV started. And what if they don't have very good veins? So now you're up to, I've seen IV starts take over an hour because of the crappy veins the person had. So we only got 30 minutes from the time we pick the blood up to the time we have to have it started. So we need to make sure that the IV is patent. If that IV is not okay, and you have to do all that, you'll go over the 30 minutes. So what we just do is we just take the blood back down to the blood bank, have them store it. Once we get the IV running, the tubing ready, at normal saline hanging, then we go down and grab it. Planning. Like I said, we need to have all of our stuff ready. We need to have the blood tubing hung, normal saline running, have it threaded through the pump. We need to use normal saline because any other IV solution will actually cause damage to the red blood cells, or maybe cause clots. We need to make sure that we're giving any pre-transfusion meds, especially furosemide and Lasix, or furosemide or Lasix, Benadryl, and Tylenol. And then we need to make sure that we have baseline vital signs. I know the notes say within 15 minutes of starting the blood, but you want to get that, take the vital signs, press start on the pump. So it's not like, it's just a good idea to have it right before the blood starts. I will tell you that one thing that I do, and I know it's not really in the book, but if you start your blood and run it through the machine through the pump really fast, right until it reaches the patient, and then slow it down to, maybe 100 for the first 15 minutes. It's going to be a lot easier because you cannot you cannot count 15 minutes until that blood is actually being infused. So you can wait for the whole time for that blood to go through the tubing, or you can just help it speed along. Just a trick of the trade. There's the Y tubing. You can see how it comes into a Y and it's got the filter. Planning. Um, this is what I was talking about. Even after the person does this in the lab, two nurses will do this at the bedside. Can be an LPN or an RN. It has to be a licensed nurse. Alright, so we are going to get the name and date of birth of the patient. We're going to make sure we have the correct blood product. We're going to double check the blood type and the RH factor of the donor on the blood bag and the patient. We're going to check the unit number on the blood product to make sure it matches the armband and the blood bank form. See if there's any antibodies, the expiration date and time. So it just gets to be kind of a routine, almost just, it goes very easy once you go through it a few times. What needs to be checked? We just said that. This is our extra slide. Alright. So, we never want to give any medicine with the blood infusing. So, like, if somebody has normal saline infusing, we can just go into the hub and give them Lasix. Not with blood. You cannot administer anything with that blood because the medication could actually help clot up the blood. Only 2 units of blood per tubing. Otherwise, the filter gets too clogged up and then you're not doing anything anyway. So just make sure that you are changing the tubing if they are ordered more than 2 units. We need to make sure that if we are using it for more than 1 unit, that blood tubing has to be flushed. We cannot allow that blood to sit in the tubing and then start the second unit because we will have to sit for a little bit while we go get the second bag, and it could actually clot off and cause more issues. Once we hang our blood and once we start it, it cannot infuse for any more than 4 hours, just because it is a huge risk for infection if it's hung any longer than that 4 hours. Some labs will actually separate the unit if it's a bigger unit into 2 so that it can be infused in 4 hours. So say it's a 500 ml bag of packed red blood cells, they might separate it into 250 so that way it can be infused like 4 hours first one, 4 hours the second one. It's just per bag per hang. And then it says, be prepared to patient support if they refuse to take any blood products. There's different cultural and religious groups that actually will refuse any blood products. But other options that we could use are like plasma expanders, erythropoietin, albumin, immunoglobulins, and sometimes they will do autologous. And it really kind of depends on how strict they are. I know I've given the Amish, who generally, as a whole, will refuse the blood products. This is just kind of review. blood added to a primed IV, like I said, you're going to want to have the normal saline hanging, prime the tubing with the normal saline, have it running at like a TKO, and then go down, get your blood, hang the blood, put it through that side of the Y tubing, and give it. While we're getting the blood, we need to make sure that we're inverting the bag of blood just so that all those cells can be kind of swished around. What else is in my notes here? For kiddos, a good rule of thumb is 50 mLs in the first 30 minutes, so we'll just run it at 100. That's generally what I run everybody at for the first, 15 minutes or so. The difference with this is that it's 50 mLs in the first 30 minutes. And then after that for kiddos, it's basically rule of thumb is 275 mLs for 2 hours. Because generally, if they're going to have a reaction, it's going to be within the first 15 minutes. Vital signs are done at baseline, right at the start of when we're giving blood. 15 minutes, 30 minutes, and at the end. It can be kind of different for different facilities, but I think the general is baseline 15, 30, and then at the end. Once we start blood, we need to stay with that patient for at least 15 minutes. Like I said, if they're going to have a reaction, it's going to be within that first 15 minutes. So we need to be at bedside. If at all possible, I would say 30 minutes would be kind of be my optimum, but we all know that doesn't always happen, but at least the first 15 minutes. Each facility is different, though, especially with what I'm saying is with the vital signs. Like I said before, it's what I've been used to is baseline, 15, 30, and then at the end. How fast can blood run? Generally, I do 100 for the first 15 minutes, and then I might bump it up to 150 because we need to make sure that we're getting it in within that first 4 hours. Oh, sorry, I'm getting tired now. If there is no reaction, say we do the 15 minutes and there's no reaction, there's no temperature spike, there's no back pain, there's nothing, then we're going to up the IV flow rate after that first 15 minutes, so it's completed in 2 to 4 hours. It's not usually done by gravity. I've never done it by gravity, so we've always just done it by pump. How long can blood tubing hang? 4 hours and only 4 hours. Because like I've said before, it's a big risk for infection if it hangs for any longer. Woo! Sluggish blood transfusion. Use a pump. Because you can't, like I said, we don't usually do it by gravity. Because the IV could be positional and you have no way of regulating it to make sure it's done within 4 hours. We need to make sure that IV site is patent, and we can add more saline. Figure out where I'm at in my notes. I have the old PowerPoint, so my notes are kind of screwed up. Alright. Once that transfusion is complete, we want to make sure that we're flushing the tubing with the normal saline. Make sure to get all of the blood into the patient. The blood bag and the tubing will go in the biohazard bag. Sometimes the facility wants the blood bag sent back to the lab just in case there's any, issues later, because not all because there might be transfusions later than, the first 15 minutes. I think the notes on this one say flush until the tubing is pink, but no, flush it until it's clear. And then documentation. We just need to make sure that we're documenting the details of the verifications, where the two nurses, their vital signs, any symptoms of a reaction, and any notification or orders if there was a reaction. So I know in VROCA, and I think it's the same paperwork. It's got to be the same paperwork. There's a little carbon copy paper that has all of the important details on there. Both nurses have to sign it. There's a place for baseline vitals. There's a place for end vitals. Just has everything on it. When we're documenting, also try and document how they tolerated the procedure, both what they said and what you saw. If they are tolerating the volume, and we need to make sure that they're having good urine output, and then any adverse reactions. Adverse reactions can happen anytime during transfusion, but generally within the first 15 minutes, especially the more serious, the life-threatening ones. But there is a thing called delayed reactions that can actually happen days or weeks after the transfusion. That's why we're going to send the blood down to blood banks so they can store it, so that in case there is a reaction, so they can do some more testing. The allergic transfusion reaction is generally the most common. It happens within the first 15 minutes. Biggest sign is that temperature, that baseline temperature, goes up a degree. And I know sometimes we kind of did that last time I gave blood, we had kind of an issue because one person took the baseline temperature and did the forehead thing, and then another person took the 15 minutes and they used the oral thermometer. So there was a discrepancy in it. I think it was raised 0.9. But then I had the same person that took the initial one come in and do it with the forehead probe, and it was, maybe 0.2 degrees off. So just make sure you're being consistent with who's checking that temperature because it can vary quite a bit. Rash, itching, and the IV site will infiltrate. Basically, it's like an allergy attack. That body senses an antigen that it does not like, and it's reacting to that from in the donor blood. There we go. That's what. These people going to have rash, hives, itching. They might complain of chest pain, shortness of breath, or respiratory distress. They might feel like they're having chills. I generally say 2 degrees or 1 degree Fahrenheit. You might see them having tachycardia, their blood pressure might drop, headache, flushing. Low back pain is a key sign for hemolytic transfusion reaction, or there might be some nausea and vomiting. Blood transfusion reaction. This is just going to be, it's going to be painful along the vein where they're in for the IVs in for the blood. It's just along the vein there. The patient, if it's suspected that they're having a blood transfusion reaction, we're going to get a UA on them, and we'll see this hemoglobinuria. And then instead of having an increase in hemoglobin that we would expect because it goes up 1 point, we're going to see a decrease in hemoglobin. And these can actually be fatal as well. Hemolytic reaction, not common, but there's going to be blood in the urine, there's going to be issues with the vital signs, and like I said, the characteristic sign is that low back pain. When the donor's blood mixes with the recipient's blood, the body is actually attacking it. They see it as a foreign object. So if they see it as a threat. So they try and get rid of it. Get rid of all of it. So the different types. There's quite a whole different load or different types. Sorry, I was looking at something. Acute things that happen pretty much right away is the hemolytic, the febrile, the mild allergic. There we go. I can't talk. Might have a anaphylactic reaction or severe allergy attack from it. Circulatory overload is very common in the elderly. Sepsis might occur, and then a transfusion-related acute lung injury. Delayed reactions might be a delayed hemolytic, hepatitis B or C, an iron overload, because it is a thing that people can have too much iron, and then like a cytomegalovirus or malaria or HIV, just something that would be passed along in the blood product. Alright, so what happens if we do have a reaction? The first thing we're going to do, and the one thing you can't see on here, but we're going to stop that transfusion. We are going to get a new bag of normal saline, and we're going to get new tubing. And here it says with new tubing. But first thing we do is stop the transfusion and then start a new line. We want to make sure that that IV stays patent. If we have blood going in or fluid going in, that vein's going to stay open. There is a chance if they are having a reaction that blood or that vein could collapse. We're going to need a UA and some blood samples. We're going to need to notify the blood bank and the provider immediately so that they can give us orders on how to go about treating this person. We're going to give our meds per MD orders, and it's going to be things like antihistamines, antipyretics, cortisone, epinephrine, morphine. Because if they're having some of these reactions, they're going to be painful. So we're going to, or we might be giving Tylenol or Benadryl, those types of things just to help treat the symptoms. We're going to monitor vital signs every 5 to 15 minutes. We're going to do it pretty regularly. They might need to elevate the head of the bed or even put on oxygen just because of if the body's destroying all the blood cells, there's no place for the hemoglobin to attach, so the hemoglobin's going to drop. We need to save the blood bag and the tubing, and we're going to send that to lab because they're going to do some more testing on it. We're going to make sure we're documenting all of this. And then I think I've got blood and urine specimens on here twice. But we'll do urine specimens and blood specimens because we're going to be looking for anything that tells us about the hemolysis, which is just the breakdown of the red blood cells. Either it's going to be in their urine or we're going to see it if we look at the blood under a microscope. Nursing diagnosis. Circulatory overload. Common in the elderly, like I said. So signs and symptoms that we're going to see, they're going to be dyspneic, they're going to have orthopnea, wheezing, tightness in the chest, they're going to be coughing, they're going to be blue, they're going to be cyanotic, they're going to be breathing faster just because they're trying to get the air in and they can't. Blood pressure is going to spike, their neck veins are going to distend. We're going to actually hear the S3 when we're listening to them, and we're might be seeing peripheral and pulmonary edema. So yeah, there's a lot of signs that are it's kind of the same. It's the same symptoms as like a CHF patient that's exacerbating. Why does it occur? It's just because the body cannot handle the extra volume of blood that's being transfused. How's it treated? We're going to give Lasix. Why not? Another thing that is on our notes is the transfusion-associated circulatory overload. It's a TACO. That's because that, like I said, that patient can't tolerate the increased blood volume, or it might have been increased or infused way too quickly. Generally, the young, the elderly, people with very small stature, or anybody who has a terrible heart function is at risk for this. Autotransfusion, we kind of went into it. What is it? It's the patient's blood being collected and retransfused into them. When's it used? Uh, when I was working ortho, and they don't do it anymore, and I'm not sure why not. But we used to, like, they'd have their surgery, and that night they would leave this machine hooked up where it was actually draining all the blood that was collecting in the, say the knee if they had the knee done. They're draining all that blood and collecting it in a bag. Once that bag was full, we would send it through the machine to be cleaned and hang it as we would blood. It was really nice because we didn't see a whole lot of low hemoglobins, and we'd had shorter hospital stays because of it. Because a lot of times when patients weren't able to go home, it was because they failed PT/OT, because they had orthostatic hypotension, and that kind of resolved while we were giving them their blood bags because their hemoglobin wasn't dropping as low. Autologous transfusions have a lower risk of infection, and it's used a lot in like times when patients have rare blood groups. We had a patient once that we didn't have the right blood for them, so their blood had to come from Milwaukee. And then I had another patient who had a person that lived 7 hours away from him, but this person that lived 7 hours away would go in and donate blood like every month or every other month, whatever it was, specifically for a specific patient. It was kind of really cool. And they did tell me a story that one day they decided to meet up and they set it up so because basically that one person that's donating to a specific person is keeping that specific person alive. It was really kind of cool. Good thing we're almost done. I'm tired and it's, I don't know, 1:32 o'clock. So, special circumstances. The biggest part I want to talk about on this slide is what if your patient refuses that blood? Jehovah's Witnesses, Amish, generally do not take someone else's blood. And I don't know, I mean, I have an idea, but I don't want to speak for anybody else. But what do you do? I had a patient once who was 93, confused, chronic UTI because of catheter, so that's where the confusion came from. Generally, 8 times out of 10 was talking out of his head. He had a low hemoglobin, he had a bleed somewhere. And brought the blood in, was going to hang it, and he said, nope, I don't want that. It's a bag of death. Okay, well, you're, kind of talking out of your head. It's not a bag of death. And so I sat and tried to talk him into taking it, and I said, well, you know what happens if you don't, get your hemoglobin back up? Yep, I know damn well what happens. Okay, let's try. Come on. And I kept trying to get him to take it. Come to find out, he was having a period of lucidity, and his wife had been gone for 4 years. And he even said that to me. He's like, well, my wife has been gone for 4 years, and I'm kind of tired of being the hero, so I'm just ready to go. In a way, it broke my heart because I was holding something that could really help this man feel better and live longer, but yet he was done. He was tired of fighting, and his wife of 60, I think it was 66 years, had passed away, and he was just ready to go to heaven and be with his wife. So they do have the right to refuse it. It can be very difficult on us, but until that patient described to me why he wouldn't take that blood, I was like, oh my gosh, why you have to take it? But once he explained it to me, I was like, oh yeah, that really makes sense. Um, he did not get the blood, and he passed away probably about a month later. He had a bunch of some other issues too, but so just know that patients can refuse blood. If they're younger and they are a full clone, then we can try other things. Like I said before, the erythropoietin, the IgGs, whatever, albumins, different types of things. I don't get into. I think you guys can look at these things. Um, we need to make sure that we're educating our patients on the delayed transfusion reactions because they're not going to be in the hospital for us to watch at this point. Um, and that's about it. Well, I hope that helps, guys. If you guys need anything while you are studying, please let me know. Um, and I will see you guys next week for class. All right, have a good one, guys.